Yes, so I'm Dr. John Tay. I've got a special interest in cannabinoid medicine. I consult privately in integrative health, dealing with, as you know, as GPs, a myriad of convoluted polypharmacy and medical problems that our patients have, and help ease their symptoms through nutrition as well as their conventional medication, and now integrating cannabis into that system as well. So I've got a fair bit to get through today, but before I'd like to start, I'd just like to thank MediHuanna, Dr. Teresa Taupik, for getting this course accredited for the RACGP and everybody here to get points for their continuing medical education. And I do think it is an amazing step in the legitimacy and the provision of available medicinal cannabis in Australia. So we're all privileged to be here, and I feel especially privileged, so thank you. So I'll get right into it. I'm going to talk about a few things today, but I'll start with chemotherapy-induced nausea and vomiting. So, does cannabis work as a treatment for chemotherapy-induced nausea and vomiting? And preliminary studies, though we do need more evidence and larger cohorts, states that it is effective as an antiemetic agent. And there's a study, a double-blind, randomised, controlled, placebo-controlled, phase 2 clinical trial, which was published in the British Journal of Clinical Pharmacology in 2010, on the efficacy of oromucosal standardised cannabis extracts in CINV. And to summarise that, 71.4% of people responded well to this medicine. So I think we can say yes, it is an effective product, and it is working for patients on the ground. So how does chemotherapy-induced nausea and vomiting? Well, free radicals created by the chemo induce serotonin release from the gut, which interacts with the serotonergic neurons to release dopamine via the chemoreceptor trigger zone. And this is the usual base of action for our standard antiemetics, as I'm sure you're all aware. So how does cannabis work in this situation? As Teresa mentioned, cannabinoids interact with our endocannabinoid system via interaction with the CB1 and the CB2 cannabinoid receptors, mainly in the central nervous system. Now, cannabis acts in a different area than our standard antiemetics. So, in the dorsal vagal complex of the medulla in the brainstem, THC binding to the CB1 receptors suppresses vagal stimulation, which then has its antiemetic effects. Additionally, CBD, or cannabidiol, is thought to suppress nausea and vomiting in our patients via modulation of the serotonergic receptors, again in this dorsal vagal complex. The munchies. I'm sure everyone's heard about that with THC. It's a very common thing, and improved appetite is actually a side effect of medical cannabis, which we can utilise to our benefit. So the increase in appetite that's produced by cannabis has obvious therapeutic potential, especially in the cancer patient and chemotherapy patient. So it helps them eat, basically, and keeps them weight on, or just even eat at all. As we know, when you're undergoing chemotherapy, appetite suppression is a really serious problem, and weight loss is obviously poor for healing in these patients. The other areas of potential benefit for chemo-induced nausea and vomiting patients who generally have cancer would be chemotherapy-induced neuropathy, help with their sleep, so reprieve from insomnia, help with their depression and their life situation, which is overwhelming at times, and of course help with cancer-related pain as elucidated by Dr. Taupik. So from a clinical perspective, and this is where I like to stand, I'm not a researcher, I'm a clinician. When do we use this medicine? Well, when standard antiemetics fail, as we've elucidated, cannabis is not considered in Australia as a first-line medicine. So when standard emetics fail, cannabis should be considered, I believe. And they can definitely be used in conjunction with standard emetics, and they often result in a decreased dose of those standard emetics. And how would the patient take it? Well, the route of absorption of medicinal cannabis can be through many methods. And I think in the acute sense, when a patient is acutely nauseous, inhalation via vaporizer would provide the quickest mechanism of action. The onset of that action is very quick, sometimes 10 to 15 minutes, but it has a short duration of action, so perhaps only 2 hours. As a preventative measure, I think sublingual or oral medicinal cannabis drops in an oil format is a very effective way to dose your patients, because the pharmacokinetics of this administration method result in a longer duration of action. So a slower onset, about an hour or two, with a 4 to 6 hour duration of action. So during the chemotherapy on phases, or the periods when nausea is the worst, when the patient's getting administered chemo, before they start vomiting, we can use this prophylactically. Another area which is approved in Australia for use of medicinal cannabis is epilepsy. Now, this is a very emotive area. We've all seen this on the television, young children with intractable epilepsy, Dravet syndrome, etc., having 50, 100, 200 seizures per day. And this is, of course, very distressing for the family and the patient themselves. And in Australia, where there's lots of anecdotal or observational evidence that epilepsy is an area where much benefit can be gained, especially in the use of the secondary cannabinoid, the lesser known cannabinoid, cannabidiol CBD, which I must point out is a non-psychoactive component of the plant. So it's better for use in children ethically, I think. So there are a lot of studies done on this, and once again, we need more sample size. But if anyone's interested in epilepsy in particular, I would urge you to look up Dr. Bonnie Goldstein in California. She's an expert in medical cannabis treatment for epilepsy, and she's got ongoing trials using CBD, mainly though adding small amounts of THC. And also to look at the Israeli experience, and they've recently put out a study on their experience in Israel. They've been using medicinal cannabis for a long time over there. As we know, it's the basis of MediFarm with their Tikkun Olam strains. And once again, a lot of positive benefits are attributed to medicinal cannabis in this area. So this is Charlotte Figge. She's made famous this strain, or Chemovar Charlotte's Web, which is a very low THC, high CBD strain. So she was one of the first patients in America to utilize high CBD as her medicine, and got amazing results from that. And now that's become the mainstay, or the reason that we base our treatment using mainly CBD in children. Though there is evidence and observational evidence that adding THC in small amounts to these patients can be effective. And I might add similarly that this is the same for an adult patient, though it just doesn't get as much media. So how does this actually work as an anticonvulsant? What's the mechanism of action for this medicine? Once again, it's not fully understood how it works, but there are studies that indicate CBD in particular may raise the threshold requirement for subsequent action potentials in the central nervous system, making it difficult for subsequent action potentials to propagate into a seizure activity. Another potential mechanism of action of CBD is the inhibition of FAAH, which, as we'd elucidated earlier, is the main enzyme for the breakdown of anandamide in our body, which is our main endocannabinoid, or cannabinoid which is produced by our bodies. Anandamide has been shown to have neuroprotective and anticonvulsant actions. So this is the hypothesis of how CBD works for anticonvulsant activity. THC has been seen to have anticonvulsant activity as well, and as we mentioned, the full plant medicine and entourage effect of multiple compounds within the plant, it should be, I think, included in the epileptic patient, though with care in young children, and I think in adults care as well, but it's more likely to be used in an adult situation. THC is thought to have its anticonvulsant activities via its interaction, once again, with the endocannabinoid system in the central nervous system. More research is needed to be done in this area, but it is occurring. In other considerations in the anticonvulsant mechanism of action, cannabinoids interact with the endocannabinoid system in our brains to modulate the calcium release in neurons. And excess calcium in and around our neurons of our central nervous system are known to be neurotoxic and increase neuronal excitability and therefore seizure activity. This has a particular effect on T-type calcium channels or low voltage regulated channels. Cannabinoids additionally have been shown to decrease glutamate levels in the brain, which is an excitatory neurotransmitter, as I'm sure you're all aware. So once again, studies need to be continued, they need to be done, and they are occurring. And when the first-line conventional medications are deemed ineffective, I think once again cannabis is a very good treatment option. Cannabis can be used in conjunction with standard epileptic medications or conventional epileptic medications, though careful patient monitoring is required in these cases, and I'll talk more about this later in pharmacological interactions. So from a clinical perspective, how do we deal with the epileptic patient? Standard procedure initially for your consultations, full blood counts, UNEs. We need to note the epileptic drugs that the patient's on with special attention to the blood levels of these drugs. And these, importantly, clobazam in children especially, that's a common anti-epileptic drug, valproic acid or phenytoin or dilantin, felbamate and stiripentol. Treatment of the epileptic patient often involves higher levels of CBD. As Teresa mentioned earlier, CBD is not as potent a compound, so more milligrams of the drug are generally used to get a therapeutic effect. However, increasing the CBD levels in our patients potentially has the ability to affect our cytochrome P450 enzymes in our liver, which is involved extensively in drug metabolism of all types and all conventional drugs, as well as CBD and THC. A baseline EEG would be a good idea to get a number of seizure frequency. I encourage the patients to start a seizure journal if they haven't already started one, prior to commencement of treatment with cannabinoids if possible, to get a baseline and then to indicate efficacy and dose rates and give us the ability to change those with knowledge. It's also important to take time to titrate for your patients, and I always tell my patients this may take 3 to 6 months for us to get this level correct, especially in the epileptic patient because of the patient's individual endocannabinoid system and the requirement of higher levels of CBD. So to start low and go slow, it's a mantra you'll hear a lot in the medical cannabis circles, and I think it's a very good mantra, but it allows us to safely increase and titrate drugs to their own level. So we may need to adjust the doses of the standard anti-epileptics or seizure medications, as I'll explain further in a second. I think the best route of administration for medicinal cannabis in the epileptic patient would be sublingual drops or oral drops. I say sublingual because if we can encourage the patient to keep the drops in their mouth for as long as possible before swallowing, we do avoid a bit of the portal circulation and then thus the immediate hepatic metabolism of their medication. So the medication is more effective if it can be held in the mouth a little bit longer, though inevitably people swallow the medication and it becomes an oral pharmacokinetic profile as well. So dosing, how do we dose? We start low and we go really, really slow. I'd start at about 1 milligram per kilogram per day in 3 divided doses for the patient. Now this is very low, and this is referring to CBD, by the way. And then we'll bring that up slowly every few days, every week, increasing this dose. And observationally in children, doses of anywhere between 12 to 25 milligrams per kilogram per day in 3 divided doses seems to be quite effective. If there's no effect by about 10 to 15 milligrams of CBD and the patient is applicable to using some psychoactive THC component in their medication, then that's probably a good time to try a very small amount of THC into the mix of their medications. So starting, as I say, 2.5 milligrams, then up to 5 milligrams. But in the epileptic patient, THC is something which we can ease off on and use more CBD. But saying that, every patient is individual, and their endocannabinoid response will be individual to the medications we're giving. So you may need to increase those levels there. Interestingly, though, at the moment in Australia, a non-decarboxylated form of THC, THCA, or the acid form, which is basically the raw plant form of the medicine, which has no psychoactive effect, it's as if you juice the plant. This has been shown to be useful in children in Australia in individualised cases. So that's an area which I think we need to look further at, and could be very beneficial, especially in the child patients, because you're not getting any psychoactive effect there as well.